I am very happy to be here. I herald from Virginia, and I am from Old Dominion University, and I'm going to talk to y'all for a little while about how we are preparing our CNS students to address population health disparities through technology. I really enjoyed the talk this morning because I'm a kind of a telehealth techno geek, if you want to call it anything. And I'm curious as I start this presentation, how many of you in here are faculty members? Cool. Okay, so I'm really talking to you. And then I want to ask, how many of you are doing telehealth? A few. Okay, so I'm going to talk a little bit about how we've incorporated telehealth into a one-day immersion experience for our DNP students, which include CNS, advanced practice nursing students. So CNS is a cohort of this group. So here's where I come from. We also have a large bridge that connects us to, actually we're kind of a peninsula, so we're connected by bridges throughout, which is kind of the goal of this, or the kind of a focus of this conference. This presentation is HRSA funded, so I need to give a shout out for that. Hopefully at the end of my 15 minutes, I will be able to provide strategies for you to develop a similar program, and you'll be able to identify how this can be accomplished really in one day. And I'm going to talk a bit about our outcomes as a result of this one-day experience. So we know that CNSs are unique in that we are in facilities, both inpatient and outpatient, to reduce costs, improve care. I'm singing to the choir. Assist in safe and effective patient transfers, which is a big part of what we're teaching our CNS students. We're embedding them not only in acute care settings, but also in community settings. And one way to really bridge that care is through telehealth technology. And really, the CNS puts all of the pieces together, and what better way to put the pieces together than through telehealth? So telehealth, for those of you that didn't raise your hand, it is not a practice in itself. It's really a modality. And as we think about telehealth, many people think about certifications or they think about subspecialties in telehealth. Kind of take that out of your mind. It's just another way of providing care, and really good care, to our patients. It's really essential that the CNS is prepared to use this technology from various angles, whether they're in the hospital and responsible for buying the equipment, for teaching individuals how to utilize the equipment, or they're actually providers using telehealth. It's essential that we know what to do with it, and we have to prepare our students. What's happening in the field of telehealth right now is this technology is landing in hospitals, it's landing in clinics, and people think, oh, it's sexy, it's great, let's use it, but they're not taught how to use that equipment, how to buy the best equipment, what the policies are behind that equipment. And it's our responsibility as educators is to fit that into the curriculum. So that's what we're going to talk about. And also, if you go into the literature and you read about facilities and schools that are teaching telehealth, they're really just talking about didactic content. They're not talking about hands-on experiential activities. That's really the way we need to learn about telehealth. So I like to say, let's make soup. So for those of us that are in faculty positions, we are being challenged to fit a lot into really tight curriculums. We're being told to do interprofessional education, telehealth, social determinants of health. How do you get all of that in? So what I propose is we make soup, and we do it all in one day together. Okay, so that's kind of what I mean by making soup. So we have created this one-day experiential program with a very complicated standardized patient. Do you guys have standardized patient programs? Okay, we have a robust standardized patient program that's at our medical school that is separate from us, but we contract with. So we take our students into this setting to use standardized patients. And so what we've done with this day is we very thoughtfully laid out how the students would go through the technology. We started our standardized patient in the hospital setting. We moved them to the clinic setting, and then we moved them to the home setting. So the students traveled from setting to setting, providing care with various forms of technology. Okay? So I'm going to now take you through our standardized patient. We wanted her to have multiple negative social determinants of health. We wanted them to have a lot of issues. So in Virginia, that one of the bridges I told you about connects us to the Eastern Shore. It's a $25 toll to get to the Eastern Shore, and it's a 25-mile ride to get to the Eastern Shore. Most of the people that live on the Eastern Shore are immigrants, and they're migrant workers. So we made this a child of a migrant working family living on the Eastern Shore with one car. So they are an intact family where the parents, it's an ESL family, and they are isolated by miles, by car, and they're uninsured. Okay, so they're living on this town. They do have Medicaid insurance. She's sick. The child has Medicaid, but the family is uninsured. So this is a busy slide, but this is what the students were given when they came to campus that day. We wanted them to understand how the trajectory of the patient would go through the system using the various pieces of technology. To keep costs down, everybody didn't go from the hospital to the clinic to home. Okay, if we did that, we would have had a lot of standardized patients. We frankly wouldn't have had the room for it. So we told the students this is the trajectory of the patient, but you might start in the clinic, you might start at home, and you might start in the public health department. So you following me? So they were given this grid so they would know how they were going through the system. So the students were given directions when they went into each one of these rooms, whether it was the home, the hospital, or the clinic. And they were given information on telehealth regulations with regards to that equipment and whether they could bill for it or not. That's a big part of telehealth. Is it reimbursable? Is it not reimbursable? How expensive is the equipment? What's the overhead for the equipment? Do you have to have cloud-based technology? They didn't know all of that. So we gave them that information in each scenario. And they were also challenged because we realized a lot of times, we've been doing this type of education for a couple years, and we realized students would go in and they'd look at the equipment and they're like, oh, that's a lot of fun. Look at what I can do with this. Look at how the button pushes. But they didn't think about how they could use it. So we told them they had to have 3 barriers and 3 benefits to that piece of equipment when they walked out of the room. And we had a flip chart outside of the room, something as simple as sticky notes. They had to write on their little sticky note 3 benefits and 3 barriers and put it on the flip chart when they walked out of the room. Super simple, but it really made them think. I'm telling you, in previous years, they didn't do that. They would walk out like, that was a lot of fun, and move on to the next room. So it really changed their learning. And also giving them the handout of the regs in the state really made them start thinking. And we also told them that every state had different regulations. So we have students coming from outside of Virginia. So we only gave them the Virginia regs, but explained if they lived in another state, they really needed to go back to their home state to figure out what they needed to do there. So I'm going to take you through our rooms. So the first room was the hospital setting. And what we had was a Vigo robot. So I don't know if you're familiar with a Vigo robot. It's just one of the pieces of technology that can be operated from a distance. So they were sitting, half the students went into the room with the patient, and the other half went into the room where they operated the Vigo off of a computer. And they'd roll the Vigo through the hallway into the room with the computer. You know, if you can imagine, they're like, oh my gosh, look at what I can do. And the Vigo here would go in. The patient is on reverse isolation, okay? So they sent the Vigo in without a human being to visit with the patient and to assess the patient virtually. And what was fascinating was as I sat in the other room and challenged them to think about how they would use that Vigo, they thought of things I'd never thought of before. For example, our hospital administrators said, you know, my infection control surveillance rates are really low. I have really low compliance with that. Wow, I could send the Vigo into the room, and they could do, the Vigo, the person outside could send it in. I've gone down on my gowns, I've gone down on my masks, I've gone down on my gloves. They do the visit, the Vigo comes out, we wipe it down, go into another room. So that's the kind of thought process that happened during this visit. Home-based monitoring is critical for our patient that is on the Eastern Shore. They're isolated. They can't come back regularly. So what we did with our home-based equipment is they visited with that patient both synchronously and asynchronously. So for my non-telehealth people, asynchronous is when it's not happening in real time. So what they learned how to do with their home-based technology is how to read trends, how to read temperatures, how to read weights, how to read pain scales that were coming across this technology, and they could then pull up several days later and see the graphs and the trends. Synchronous is they could do a real-time visit. So we eliminated on the Eastern Shore, oftentimes they have a very low rate of home health nurses over there. They just don't stay on the shore. They don't work on the shore. But this patient needs to be home and seen by a home health nurse. So you can ship this equipment to the house, and the nurse back at the big house at the children's hospital can do that visiting with the patient like the home health nurse. Down on the far right-hand corner, I like to just pitch this for a minute for those of you who want to be an investor. It's not public yet, and I have no money in this. But it's the TytoCare. Write it down. It's going to revolutionize primary care, TytoCare. That little device is the size of your hand. You can ship it to a home, and the care provider, parent, spouse, individual can send a heart rate, a respiratory rate, bowel sounds, can look in the ear, can look in the throat, and it can go real time back to providers. It's going to change primary health care. Tytocare. It's not public. I mean, you can buy one for $300 right now. And if you are the provider on the back end, you can buy one for, you buy your dashboard for $1,800, and then you have a subscription plan monthly. And that's the cool thing. The Vigo is $1,800 too. So for those of you that want to build a program like this for education, it's not that expensive. And we don't do any of the cloud-based monthly subscriptions for this because we're not taking care of patients with the equipment. We just have the equipment to allow our students to interact and to interface with it. So then our video conferencing. So what we use is Cisco Jabber. Cisco Jabber is not HIPAA secure. I know that it's not HIPAA secure. We talk to the students about what's HIPAA secure and not HIPAA secure. Side note, we have been doing this long enough that now our university has really gotten excited about our work, so we're building a telehealth training center. And in our telehealth training center, we are going to have HIPAA secure platforms. So our students are going to interact with platforms that they would be using in practice. So we make sure that they know Cisco Jabber is a way to communicate. It simulates an asynchronous visit, but is not cloud-based where all of the information is secure. Okay. So what they do here is we have half that are the provider on the Eastern Shore in a rural health federally qualified clinic where the patient is visiting with the specialist back at the hospital. So they're again learning how to keep that patient in their setting and visit with the provider. So we then take them into a final room where they learn a little bit more about e-health and mobile health applications. So they are challenged to think about applications that support both the patient, the family, and that distant provider on the Eastern Shore that doesn't have access to the primary hospital, to the teaching hospital. We are, but we're not in here. But we are, yes. We can, if questions, I can explain what that is. So basically, the students were satisfied. They were actually very satisfied. So this slide is showing how real they felt the standardized patient was. Telehealth etiquette is a big part of my research platform. and it's another talk, but it's about teaching the nuances and the etiquette and the communication that goes with a telehealth visit. They were frustrated a little bit with the Vigo because we've got some students that they weren't gamers, and they had a hard time moving the application on the computer. I think if they had another day, they would fall in love with the Vigo. Home-based telemonitoring, the smartphones, mobile apps, and how would they rate the experience? Qualitative feedback, they loved it. In one of the most interesting comments that we get from students when they're exposed to something like this is, I learned more about social determinants of health in this experience than I have in didactic courses. Even though it was a standardized patient, it really hit them how isolated this individual was, and also how technology could really help to meet the needs of that patient. They were struck by the cost and that it wasn't as high as they thought it was going to be for this equipment. Any of you starting a program like this, do not buy into the $35,000 AMD cart that people want you to buy. They become coat racks in institutions. I'm serious, and I'm not kidding. If you have an iPhone, you have a piece of telehealth technology. If you have an iPad, you have a piece of telehealth technology. That's what students need to learn how to use with regards to telehealth. Do not invest in things that are terribly expensive. They will become antiquated within 2 to 3 years. They left with a new perspective and a new understanding, not only of populations that are isolated and in need of support, but how to use technology to reach them. Our graduates are actually going out into community settings. We're really pushing our CNSs into community settings. I'm going to do a shout out to one of our graduates in the back who's finishing her DNP now. She has a talk tomorrow. We embedded her in an urban-based free clinic. And she is actually running the student-run interprofessional clinic at that free clinic as a CNS DNP. Who better to lead a clinic like that? So that's really what we are encouraging our students to do, is to move out of the hospital and to reach these underserved individuals and to reach them with technology. They are becoming technology champions. I know that outcomes are important. So one of the things we're in the middle of doing right now, you probably saw the date. This course was run in May. We're getting ready to run another one this coming May. We've sent a survey out to our students, and I'm getting them back right now, asking them, as a result of this day, did they choose a DNP project that was technology-based as a result of this day? Did they go back to their home facility and investigate telehealth technologies? Did they go back to their facility and they had purchasing power? Are they looking at buying telehealth technologies? So we really want to see, did we turn the needle? You know, if I shifted the needle 10% out of 40-some students, I think that day was a success. Right now I have 10. I was sitting next to my student in the back that I'm going to do a shout out to at the opening talk. I said, did you finish that survey? Because I haven't gotten a lot back. And she was like, no, I didn't. So she pulled her phone up and finished the survey really quick. So we're going to do another push, because I'd really like to have a pretty robust return on it, because this is going to get published. And really, to have it successfully published, I think we need to have longer-term outcomes. And that will show kind of how we move the needle with regards to this class. So with that, did I do right on 15? I'm usually pretty good about that. So I have 5 minutes for questions. Do you want me to tell you what Project Echo is? The question in the back was Project Echo. We are embedding Project Echo into our curriculum now. Came out of New Mexico. It is a telehealth-based platform for primary care providers for specialty areas that is designed to flatten knowledge in that topic area. So what we're doing in one of our programs that we have is pain management out of the Weitzman Institute. So we're using their Project Echo platform. Twice a month we go on. It's case-based learning. It's kind of like a virtual Grand Rounds. And it's interprofessional, it's virtual. You get CME credit, you get CEU credit. I would look at it for your institution. The Weitzman Institute actually, CNS's, has a nursing bedside Project Echo that is enhancing the bedside nurses' knowledge. That's pretty amazing. Yes. Mm-hmm.
Okay, so the legislation and each state has different whatever, and where I work, we see patients all over the nation. So is there?
Are you at a VA?
No, I'm at cancer treatment.
Oh, so you see Oh, I know where you're going with that.
Yeah, so I'm doing symptom management from a patient who lives 700 miles from me. So.
And how are you doing it?
Right now on the phone.
Yeah.
So we're seeing that even
well,
will become an issue. We're going to have to license in all the states.
You are going to have to license in all the states.
Yeah.
It's a hot mess.
Yeah.
And
so telehealth will be kind of the same.
It's a hot mess, actually. I'm on it's CTEL. Anybody who's interested in policy, law, legislation, and telehealth, become a member of CTEL. And we're really trying to push legislation for the boundaries. Physicians in particular are held to licensure within states, so they can't. We live 20 minutes from North Carolina, and unless they're licensed in North Carolina, they don't have compact like we do, so they can't visit virtually a patient in North Carolina.
Oh.
So we're trying to look at interstate compact with nurses, and if you have an interstate compact license, you could then visit that patient across that state line. We too have, I'm also a manager of a telehealth program at a children's hospital, and we have a specialty surgical program, and people come from all over the world. And they are using that as a case study at CTEL to push the boundaries.
Right.
It's coming. Not now, but it's coming. So don't do it. It's illegal right now.
Just a comment about the contact. In Ohio, it's only for nurses, not for APNs and not for prescribers. So, for example, one of our telehealth providers has 13 different licenses for 13 different states because that's the only way
they can go across that line.
And my real question for you is, I'm in the heart failure business, and I'm part of a national steering committee of a large randomized controlled study, and 2 arms involve smartphone apps, different types of apps we're wanting to see. And the bottom line is we're having a really hard time getting patients enrolled. And this is multi-centers,
Interesting.
Yeah, they're enrolling in the registry arm and the usual care arm, but patients are saying no. So I was just curious. I mean, we're getting a lot of lessons learned. You go to the airport and you see everybody on iPhones and iPads. It doesn't matter what your age is or any other social determinants of health. But it turns out in real life we're still having a lot of trouble with elderly people, which is mainly my business in heart failure, to say yes to using an app or being involved. And so I was just curious if you're really helping students to understand the nuances with aging and using apps and having alarms that they don't understand and they don't want to deal with, etc.
We do talk about with the aging population, because we have an adult Gero course. I wonder if you used iPads, if you'd have greater success, really, because the print and the button. But interestingly, I'm surprised because adult Gero patients, or the Gero literature for telehealth is actually quite positive. And if you read satisfaction, those of you who are researchers in the room, if you read patient satisfaction, they all like it. And what the American Telehealth and CTEL are saying now is don't research that. Don't do it. What we need to do our research on is outcomes and cost savings.
At least in heart failure, what happens is they stop using it and becomes co-pack.
I wonder if it's because they're just non-compliant in general, and it's not really the technology.
I don't know, because again, these people are enrolling in the other arms of the study.
Interesting.
And we did a study a while ago. We did publish it in a journal, and we found out when we asked patients if they preferred an iPad, an iPhone, or a small device that almost looks like a little pager or a little iPhone, and I can't get up, a little teeny gadget, that the iPhone was the preferred device. So iPad was not the preferred device.
Interesting. Question?
Do you think it could have something to do with the fact that people still want to be touched?
That's a big thing.
Well,
the reason I ask that because I do a lot of community, and we do a lot of electronic stuff because, of course, says we need to push to more social media, technological things. However, the kickback is always, when you actually talk to the people, the kickback is always they
think one of the things you have to do with telehealth, and it's been our experience in the children's population, so clearly it's not geriatric, is it does not take the place of high touch and communication. It cannot take the place. It is in addition to. So what you are, if you pitch it to your patients that this is extra, I can give you more with this than I ever could if you were coming into me. You're still seeing them in the clinic. You know, with our distant program that we're doing our surgical follow-up with, we're telling them we have to see you every year. You have to come in and be seen every year, but I can visit with you virtually multiple times that we couldn't have done otherwise.
All right. Thank you, Tina.
Thank you.
Tina.
No. Oh, yeah. There we go. Yay. Thank you. Thanks for letting me know. So anyway, these are the demographics, and what does this look like, really? This is social determinants of health, right? When you boil it down, this is what we're looking at. SES and education and so forth. So right there, they're at higher risk. The other piece of urgency is to know that of the 23 states where most of the LGBT population are found, they have what we call discriminatory or negatively legal status for LGBT. So how many people here are from red states? Just looking at that. Not red as in politically red, but right. And how many from green? Okay, well, how about that? Okay, so about 39% of LGBT live in red states, and about 36% live in the darker green states. What we're really looking at when we're talking about discrimination there is 5 parameters. So youth laws and policies, health and safety, which we're really focusing on, correct name and gender identity on paperwork, adoption, and parenting parameters. So you can see that there's really a huge need nationally. Okay, the other piece of urgency is around the fact that we're still seeing conversion therapy practiced across the United States. And for this, I just want to give you a quick anecdote of a story. Now, somebody here was from Ohio. I know that I saw, okay, a few people from Ohio. And so maybe you've heard of Leah Alcorn. Anybody heard of Leela Alcorn? Okay, so she was a transgender teenager that at about the age of 14 realized exactly what was going on. She realized what the term transgender meant, and that the last 10 years of confusion and frustration and fights with her parents were really around the concept of her being transgender. So at 16, she got brave enough to ask her parents, who were already not very happy with the concept, about possibly getting transition surgery. And so at that point, they decided that they had to quickly put her into one of these conversion therapy programs. It went very badly, and she became extremely depressed. And following the conversion therapy attempt, she decided that she would walk into traffic at the nearest interstate and commit suicide. So because she managed to have this posted to Facebook, her story and the reasons why she was doing it, and messaging parents and other teenagers that were in her position, she had, I don't know how many, almost 100,000 hits on that website before the parents took it down, talking about conversion therapy and how to interact or not interact with your transgender teen. So it's still going on. And really, our practice, the CNS practice, you're in the position to maybe intervene. You might be able to see that teen or talk with that parent before it gets to this. Also, when you look at other healthcare issues, transgender people are more likely to have more days monthly of physical and mental illness, more likely to have had an MI, have a lower proportion of regular health care provider and dental care appointments. However, they do not differ from the general population as far as chronic disease, cancer, depressive disorders, other health behaviors like smoking, binge drinking, or wearing a seatbelt. Discrimination in medical care. And so here's why I'm really excited to be here. This is what we know nationally. 33% of respondents in a U.S. Survey reported having at least one negative experience with a healthcare provider in the past year, specifically related to being transgender. Now, how sad is that? Such as verbal harassment or actually even refusal of treatment. In the past year, 23% of transgender respondents postponed medical care because of fear of being mistreated, and 33% did not see a doctor because of costs. Again, you've got social determinants of health playing in here. However, statistics don't tell the whole story. And I'm going to go ahead and read some of these direct quotes just to actually give voice, literally give voice to these. So this is from one of the participants in phase 1. I'm treated as emotionally unstable and patronized by many providers. It's like they think I'm stupid and childlike. They might use the right pronouns at first, but then they give me a knowing smile and switch to sweetie and talk down to me. I have an Ivy League education, a professional license, can crush you in Trivial Pursuit, for goodness sakes. I'm not an idiot. I just go along with it, though. And this was, I think this was one of our lawyer participants. So you can see the frustration. So just tell you a little bit about the story. This is of the research. It's a 2-phase mixed methods study. So the first phase was really trying to get the language right for the second phase. So the second phase was the qualitative interviews with 12 participants. So in phase 1, we did a survey monkey with some open-ended response options, just trying again to make sure that we have the language right, to pilot some of the questions and get feedback. And then the second phase was the in-depth interviews, about an hour long, with the 12 participants. And then we used the theory of minority stress, which was originally hypothesized related to the double standard of mental health for women, as if that was a thing ever, right? Stigma and discrimination. So we went through IRB approval. We did purposeful sampling, and initially we didn't think we were going to need to do this. So we went through social media that was in the Central Texas area, and we found that by the time we were targeting 12 respondents, trying to get a number of 12 more or less, thinking about if we're seeing a pattern or hearing the same stories, but that was what we were thinking we'd get about 12. But when we were halfway through, we had mostly female to male respondents. What's that about? And we didn't prompt people, but in listening to the stories, we heard from several people that female to male participants, that they felt that it was a male privilege, that they felt that their care was different and that they had a stronger voice, which was really interesting. So then we specifically tried to sample male to female participants, and we did end up getting a few more that way. Also, just to mention that we followed qualitative reporting guidelines, so those are around like 32 items in that COREG checklist around research team study design, analysis, and findings. But we're not going to talk about that. And then just to say that there's overall evaluative criteria that we need to be sensitive to. That includes objectivity, so the idea that the researcher is neutral versus bias. And if you do have a bias, that you at least identify that bias. So I had a bias going into this that they had negative healthcare experiences. So I need to own that. And the interesting thing to me was that I found out that there are some very positive healthcare experiences, but the positive descriptions helped me understand how it was the polar opposite from the negative. So, and then are your results stable over time? Is there truth value to that? What is the larger import of your data, and how does it benefit or affect participants? So generally, just quickly, phase 1 findings summary, 4 main themes. Mispronouncing or misgendering was one of the larger themes. Lack of respect, lack of both clinical and cultural competence among healthcare providers, and struggles with insurance. So I'm just going to select one of these to read, but the first one is just a real aha, and I think we were using the terms trans-friendly in the first phase to try to figure out wording, and somebody pointed out, oh, well, trans-friendly is not the same as necessarily as trans-competent, so that had not really, I just was thinking it was, but it's not. But the second one is really compelling. When in the hospital, I was really sick. I didn't only not feel up to explaining transgender, but I was afraid if I did, I might receive worse care. Sad statement. Okay, and just profiling one statement here out of all of these. The doctor said she wouldn't talk to me about hormones until I lost 100 pounds and looked more manly. So Okay, and then in phase 2, we used phase 1 data, and for analysis, we used a program called NVivo, which is specific for managing large data sets, qualitative analysis. And we followed this process, so reading through all the transcripts before we put them into this program, and then trying to see if there was a common theme between them. And then this program helps you pick out a structure to experiences. So that was sort of the process. And just to consolidate the findings, main themes, provider practices were largely discussed, both negative and positive discrimination, challenges to navigating the healthcare system, and the need for transgender-specific education. Okay, and these are demographics. So age range, majority was 25 to 34-year-olds, although we did have a few participants in each of the other age ranges. 57% were female to male. Race, largely white, 67%. And household incomes ranged from less than 29,000 to more than 150,000. So we had a nice broad sample there. One of the positive practices described, she was frank and open-ended. She let me know a lot of details that I didn't know. She was helpful, and I got gendered correctly all the way through. And everything was handled really well, I thought. Negative, the GP really had no sense of what I meant when I said I was trans. That was being me informing her. She certainly wasn't warm and welcoming about me being trans. She didn't act like she took me very seriously. She didn't ask any questions about what it meant for me, which I kind of expected, and no discussion of what it meant for my health. So how does that happen? Discrimination. Everybody had a story. If they didn't have a personal story, they knew of a story. So this is one of this participant's best friends. She went into the hospital with abdominal pain, got in there, treatment was excellent until they found out that she was trans. And then the physician came in and said, I'm not going to treat that, and basically sent her home with Pepto-Bismol, and she died of a ruptured appendix. So I think every single participant had a story similar, even the ones with positive. And then example of navigating the healthcare system. It's just really hard to find trans-friendly doctors, nurses, etc. I'm lucky enough to live in a city where I have a couple of doctors like that. But even then, even going into the office, it's kind of like fear. I still get some looks, kind of like an experimental look, which I'm used to now. You just have to become numb to that. So if you can imagine living your life like that. Okay, transgender education. The idea that practitioners do not know much about being trans at all and have next to no education, it's really discomforting in terms of repeatedly people saying there's not enough research to know what you're doing to your body. It's horrible. Oops. There we go. So I do feel like there's something that we can do as CNS. We can practice cultural humility. We can make a really strong effort to get pronouns right and educate the people we work with in offices and settings. And remember that gender is fluid. So to ask about that, because just because they present one way one day does not mean that when you see them again in 6 months it's going to be the same. Avoid gendering body parts. So was with physicians and this Madeline Deutsch from UCSF a couple weeks ago, and she was describing how this has been so successful in their practice to broadly use the term gonads instead of testes and ovaries, and that made a difference. And then support Healthy People 2020 recommendations, and that is to collect standardized data with your patients in your setting, whatever that is. So collecting both sexual orientation and not assuming because I look female that I'm attracted to male, gender identity info, and I'll just show you quickly. These are two questions that are from the UCSF has a Center of excellence for transgender care, and this comes from their recommendations. And then also, we are trying to underscore evidence-based practice. The Cochrane resource is a great one. Their studies that are up there now are about what's effective with HIV treatment in transgender patients. Specifically, there's 2 studies there, and that's the gold standard. They use randomized control. It's the strongest. The Center for Transgender Healthcare at UCSF is amazing. So all kinds of detail there. You can click on, it's all evidence-based, and the whole left column is specific to cancer treatments, implants, just everything you can think of. So it's a great resource. Okay, and this is a picture on the far side of Leah Alcorn at age 14. So thank you for being here, and thanks for the opportunity.
We have a few minutes for questions.
Yes, ma'am.
I just wanted to make a comment. This is a wonderful presentation. I think it's wonderful that you brought it out. When I went to school back in 2005, we actually had a course in my nurse practitioner program
Oh, wow.
about, it's called human sexuality. And we were taught how to treat patients that were transgender, heterosexual, bisexual, and everything in between. And we actually had people from each different arena come in and talk to us about their experiences.
Oh, that's
I
wonderful.
assumed that this was pretty widespread, but after seeing your presentation, I see that it's not. Living where I live now in New York, we see a huge population of pretty much anything you could possibly
Yeah,
see in the world.
it's a huge spectrum. It really
Yeah,
is.
so we get kind of spoiled because we see this, but I know in rural America and a lot of different places, it's not the same. And
It's
I think
not.
it's great to bring that education forward.
I don't know if everybody could hear her content, but she was saying that in her NP program they had a human sexuality course that brought in transgender content and everything in between. Can I just see a quick show of hands of people that had it either in their CNS program or as undergrads? Okay.
See, I just assumed that it was widely spread.
Yeah.
And the things that they told me they experienced going to the doctor made them not want to go back to the doctor at all.
Right,
And
right.
so they were telling us things that would encourage, like they have the rainbow sign in the window or something like that, so that they would know they would be gender friendly,
Yeah,
those kinds of things.
good
So
point.
this is great.
Well, and we heard a couple of different stories about participants terrified of being in a car accident. Because what if EMS finds out that you're the gender they're not expecting and they walk away? They won't treat you. Yes, ma'am.
I'm a CNS student, and I also work as a bedside nurse, and I live in a great state, Minnesota. But I actually still, as a bedside nurse, we actually had mandatory education go through for the bedside nurses about like the right pronouns. It was the first time I saw it. We just had it.
Oh, that's so wonderful. The hospital mandated that? Oh, that's wonderful.
I think all the bedside nurses had attended, yeah.
Yeah, would have made a big difference in this setting. I guess you can guess what state I'm from. Yes, ma'am.
I'm from California. We had similar stuff, and I work at a pediatric hospital, so we have a pretty large adolescent population. We actually have a transgender clinic,
Oh, that's fabulous.
which is wonderful. But one of the most illuminating things was having a few adolescent transgender patients that came and spoke to our nurses. And basically, one of the things that was so basic was, we know we're trans. Like, it's okay to ask us, what pronoun do you use? That kind of stuff. Like,
Yes.
it's not like a hidden thing. And I think just having someone say to the nurses, it's okay to ask. Like, it's not something you have to be like hush hush about or like,
Right,
we know.
right.
Like,
Right.
so that was interesting that was like what hit home for our nurses the most, is that
So important.
it's not
Yeah.
it's not something you have to keep secret. Like,
No,
you
no,
have to ask
no.
them, like, what pronoun do you prefer?
Right, right, right. Very interesting too. The treatment with endocrinology now, and the hormone blocking and so forth. Yes, ma'am.
Well, I graduated from a mixed
That was it.
Yeah, and there was, transdressing and what all of that, but there was nothing about transgender. Never came to
Right.
us about 10 years ago. I think a couple people in the media have really brought the term to light. Chaz Bono, Caitlyn Jenner, being the biggest advocate.
Yes.
So it's time we look at our curriculums, undergrad curriculums, and make some changes there.
Yeah, I'm so glad you bring that up. I'm just barely, if anybody's interested in doing that, if you look at the Cotter model of change, and the very first thing in the Cotter model, and there's like 7 or 8 steps, it's very straightforward, very easy to use, is presenting the urgency of the issue. And I did that with some of our undergraduate faculty recently, and now people are weaving it in, like you were able to weave it into your curriculum, so to speak, for ethics. And so all of the BSN courses now at each of the levels have something woven into one of the key courses that all the students take that's not elective, in some way or other to eliminate the problem. So, yes, ma'am.
Our healthcare system very proudly opened an LGBT healthcare center, which was really fabulous, and I was so proud to work for a system that did that. But in one of the discussions about the education, I was kind of saddened at the fact that there was this constant conflation of sexual orientation and gender identity. And I finally had to step in on a conference call and say, let's be clear, those are two separate
Yes,
things. And
ma'am.
I was met with, oh yeah, whatever.
Yeah, yeah.
I said, well, it's not really whatever, it's an important distinction.
Oh, yes.
So even being, very, very proactive and very modern in our treatment, there's still that well, whatever, it doesn't make sense.
Oh, yeah. I mean, we're the worst, and that's why we should be. Yes.
I do have one question that we struggle with sometimes. Is how do you handle that in your computer health records? Because sometimes we end up with a patient that comes in with one orientation, and we still have semi-private rooms in New York, and it's difficult to decide who goes in the room with that person based on their sexual orientation or their gender identity. So how do you handle that?
I have no idea how to handle that computer-wise in the system, but I bet somebody else does.
One of the issues that I bring up in the ethics course is what would you do? You're on nights and someone comes up from urgent care and this is what's presented to you, and that you need to respect their gender identity and that they should not be moved out of a room because of someone else.
Right.
And so we really do promote that.
I work for the VA, and I just want to say that I'm really proud of them because they have made a huge push in transgender education, and a lot of really specific stuff for how do you work with a transgender patient when they come to your clinic, and how do you ask the right questions. And it was very interprofessional, so not just nursing, but really addressing all specialties. And we had a transgender veteran on our unit. We actually gave her a private room to kind of make that easier if we were able to do that. But thank you.
It's wonderful. Did you want to speak to that? The only thing I can see is when we get it into the system, it just needs to be entered into the system as far as how to handle that. One participant, just tell her real quickly, talks about going for a colonoscopy, and on the form it said male, female, and other. And the participant said, just knowing, he said, I didn't need the other because I'm a trans man, but it had other, and that was encouraging. Yes.
We use Epic, and I don't know if other people use
Epic,
but we
okay.
add it into our patient header. So it has birth gender and then identified gender. It has a bunch of different
Oh, wow, that's so good to know.
right there in the patient header.
Epic, okay. Thank you.
Well, our time is up, so I'd like to thank Sherry for the information.